Good evening, all. I'm Dr. Santhosh, working as Associate Professor in the Department of Prosthodontics, ESIC Dental College, Gulbarga. So I know you have been going through a lot of sessions since the morning. It is quite difficult to be alert and awake, especially during the postprandial sessions. But however, I'll try to make this session a bit interesting with some interactive videos and clinical insights. So let us move into the topic without wasting much of the time. So the topic for today's discussion is muscles of mastication and its prosthodontic significance. So these are the headings under which I'm going to discuss the topic of muscle of mastication. Going into the introduction, muscle is a Latin word musculus, which means a contractile tissue. It is a specialized contractile tissue within the muscular system, which permits the movement of the body, maintains the posture, and circulates the blood. So there are three types of muscles: the skeletal, smooth, and the cardiac muscle. The skeletal muscle is a type of a muscle which originates from a fixed bone and it gets attached to a bone which is mobile, and it creates a coordinated voluntary movements of the parts of the body. So the movements which are created are voluntary in nature when a skeletal muscle is considered. But however, in a smooth muscle, the smooth muscle are the muscle which are lining the internal vital organs like the trachea, the bronchi, are the smooth muscles. The difference between a skeletal muscle and a smooth muscle is that smooth muscle is involuntary in nature. It is not under our control. And the third type of the muscle is the cardiac muscle. It is present in the heart and it is a very highly specialized tissue. So the muscles of mastication comes under the classification of skeletal muscle because it brings about movement of the mandible. Broadly, it can be classified as the major muscles and the accessory muscles. Major muscles are the masseter, the temporalis, the medial pterygoid, and the lateral pterygoid muscle. Accessory muscles are the suprahyoid muscle, the infrahyoid muscle, and the other muscles of the buccal mucosa, cheek, and the tongue. Functionally, muscles of mastication can be classified as elevator muscles and depressor muscles. Elevator muscles are the muscles which elevates or closes the mandible, and depressor muscles are the muscles which depresses the mandible. So there are three elevator muscles which are the masseter muscle, the medial pterygoid muscle, and the temporalis muscle. The depressor muscles are the lateral pterygoid muscle, the anterior belly of the digastric, the mylohyoid muscle, and the geniohyoid muscle. So the first muscle of significance to us is the masseter muscle. The masseter muscle is a quadrilateral muscle which covers the lateral surface of the ramus of the mandible. Conventionally, two heads have been described for the masseter muscle, the superficial head and the deep head. And later, a coronoid part or the coronoid head was also described. So basically, there are three heads of the masseter: the superficial, deep, and the coronoid head. This is a research article which first described the coronoid part of the masseter in the Annals of the Anatomy. So coming on to the origin and insertion of the masseter muscle. The masseter muscle gets originated, the superficial head arises from the zygomatic process of the maxillary bone and it runs downwards and backwards, and it gets inserted into the angle of the mandible. You can see here, this is the messeteric tuberosity of the mandible. So the superficial fibers gets attached to the angle of the mandible on the lateral aspect. Whereas the deeper part arises from the posterior 1/3 of the inferior surface of the zygomatic arch. The fibers run vertically downwards and it gets attached to the middle portion of the ramus of the mandible. The coronoid part arises from the deeper surface of the zygomatic arch and this gets attached to the coronoid process of the mandible. This is the origin and insertion of the masseter muscle. The nerve supply is by the masseteric nerve, which is a branch of the anterior division of the mandibular nerve, and the blood supply is by the masseteric artery, which is a branch of the maxillary artery. So this shows video of the origin and insertion of the masseter muscle. You can see it is present on the lateral aspect of the mandible. It arises from the zygomatic process of the maxilla, the anterior 2/3 of the zygomatic arch, which is indicated in red color. The coronoid part arises from the deeper surface of the zygomatic arch. And then it runs downwards and backwards and gets attached to the angle of the mandible on the lateral aspect. And the arrow mark points to the deeper head. It runs vertically downwards and gets attached to the middle portion of the ramus of the mandible. The coronoid part gets attached to the coronoid process of the mandible. So going ahead with the action of the masseter, a point to be noted in this slide is that for any muscle, the action of any muscle is opposite to the direction of the muscle. So in this slide, we can see the superficial head arises from the zygomatic process of the maxillary bone, and it runs downwards and backwards. So what could be the action of the masseter muscle? The superficial head helps in closure of the mandible and protrusion of the mandible. It pulls the mandible upwards and outwards. But whereas you can see the deeper head of the masseter muscle, it runs vertically downwards from the posterior 1/3 of the zygomatic arch, and it gets attached to the lateral surface of the ramus of the mandible, and hence the action of the deep head of the masseter muscle is only closure of the mandible. So this is a video which shows how do we palpate the masseter muscle. It can be palpated from the origin, which is the inferior surface of the zygomatic arch, and slide your finger downward along the path of the masseter muscle up to the insertion of the masseter muscle near the angle of the mandible. So during the entire process, you can see the patient clenches his teeth so that the masseter muscle is more prominent and it can be easily palpated. On the contrary, it can be palpated on the inner aspect as well. You can put your finger, and also the thumb can be used to palpate the anterior border of the masseter muscle while the patient clenches during the entire procedure of palpation. So what is the significance of the masseter muscle? The masseter muscle has an influence on the distobuccal border of the mandibular denture. As you all know, you have seen the video, masseter muscle is a bulky muscle which runs outside and behind the buccinator muscle. So when the patient chews, or when the patient has a power stroke, as in the case of chewing a hard food substance, the masseter muscle gets activated and it pushes the buccinator muscle anteriorly forwards. So this creates a notch on the distobuccal border of the denture. This notch is called as the masseteric notch. How do we record the masseteric notch? The masseteric notch can be recorded by fabricating a special tray, and you can relieve the special tray on the distobuccal border, and green stick compound can be placed, and then the special tray is inserted into the patient's mouth, and the clinician applies a gentle downward force, and the patient is asked to close against the downward force of the clinician's finger. This way the masseter muscle gets activated, and the masseter muscle pushes the buccinator muscle forwards, and it creates a masseteric notch on the distobuccal border of your special tray. Recording the distobuccal notch is of high significance, because if you are not recording the masseteric notch, then the masseter muscle can unseat the denture, and it also can create a muscle soreness in the distobuccal border of the mandibular denture. So these are two articles shows what is the effect of lower complete denture on the masseter muscle. Both the muscle evaluated a complete denture wearer and a non-complete denture wearer, and found out that when patient uses complete denture, the thickness of the masseter muscle increases. Not only the thickness of the masseter muscle increases, the masticatory efficiency and the chewing efficiency of the particular patient also improves. So it is always advisable that we advise the patient to go ahead and fabricate a complete denture in case of an edentulous mandibular arch. Masseter hypertrophy. It is disorder which is of an idiopathic origin. As of now, no concrete etiological reason has been found out. But however, literature points out to parafunctional habit as well as usage of chronic usage of chewing gum to be the reason behind masseter hypertrophy. Additionally, patients were subjected or patient underwent surgical resection of the masseter muscle to treat the hypertrophy of the masseter. But however, recently the botulinum toxin is being used for facial aesthetics. So botulinum toxin can be injected into the masseter, which creates a atrophy, which causes atrophy of the masseter muscle, and it is found to be very effective in treating masseter hypertrophy. But however, long-term use of masseter of botulinum toxin is being contraindicated, because long-term use causes severe atrophy of the masseter muscle, and it is going to have an adverse effect on the chewing efficiency of the patient. So maybe for a short-term use, you can use a botulinum toxin and treat the mesenteric hypertrophy. The next muscle of significance is the temporalis muscle. It is a fan-shaped muscle, fills the whole of the temporal fossa. 3 fibers are present, which is the anterior vertical fibers, the middle oblique fibers, and the posterior horizontal fibers. This is the origin and insertion of the temporalis muscle. You can see it gets originated in the superior temporal line up to the inferior temporal line and the deeper surface of the temporalis fascia. The anterior, middle, and the posterior fibers unite together, form a tendon, and it gets attached to the coronoid process of the mandible, predominantly on the medial aspect, but some fibers might be present on the lateral aspect as well. Nerve supply is by the temporal branches from the anterior division of the mandibular nerve, and blood supply is by the deep temporal branches of the maxillary artery, the middle temporal branches of the superficial temporal artery. This is a video which shows the origin and insertion of the temporalis muscle. You can see it is a fan-shaped muscle which has its origin on the lateral aspect of the skull. The red color portion is the origin of the temporalis muscle. It arises from the temporal line, and all 3 fibers unite together and it gets attached to the coronoid process of the mandible. We can see attachment is on the medial aspect as well as on the lateral aspect, and it runs downwards along the ascending ramus of the mandible. Sometimes it goes even deeper to the retromolar pad, which is of clinical significance, and this is one reason why there is not much bone resorption in the retromolar pad area. Action of the temporalis muscle is that anterior fibers causes mandible to raise vertically upwards because the direction is from top to down, so it helps in closure of the mandible. Middle fibers elevates and retrude the mandible, and posterior fibers retrudes the mandible. So this is the palpation of the temporalis muscle. You can palpate the anterior, now palpating the middle portion of the temporalis and the posterior fibers of the temporalis muscle. And during the entire process, you can ask the patient to clench the teeth. So anteriorly in front of the TMJ and above the zygomatic arch. And in case of the middle fibers, you can palpate the temporalis muscle exactly above the temporomandibular joint and posteriorly behind the ear. The next muscle of significance is the medial pterygoid muscle. It is also called as the internal pterygoid muscle. So there are 2 heads, the superficial head which is smaller in size and the deeper head which is larger in size. The superficial head arises from the maxillary tuberosity, run outward, backward and laterally, gets attached to the angle of the mandible. Deeper head arises from the medial surface of the lateral pterygoid plate. You have 2 plates here, one the medial pterygoid plate and the lateral pterygoid plate. The deeper head arises from the medial surface of the lateral pterygoid plate, runs outward, backwards and laterally, and it gets attached to the angle of the mandible. So again a video which shows the origin and insertion of the medial pterygoid muscle. You can see it arises from the medial surface of the lateral pterygoid plate. So this is the deeper head which arises from the medial surface of the lateral pterygoid plate. And the superficial fibers arises from the maxillary tuberosity and it gets attached to the medial aspect of the angle of the mandible. This is the area of attachment of the superficial fibers and the deeper fibers of the medial pterygoid. What is the action when both the muscle fibers, right as well as the left, contracts? It causes elevation of the mandible, and unilateral contraction brings about mediotrisive movement. Palpation of the mandible can be done intraorally. The index finger can be placed distal to the 3rd molar tooth and directed superiorly upwards and posteriorly and backwards. This way medial pterygoid attachment can be palpated. This is how a medial pterygoid muscle can be palpated intraorally. Next muscle is the lateral pterygoid muscle. You have, like the medial pterygoid muscle, have two heads, the superior head, which is depicted in yellow color, and the inferior head, which is depicted in the violet color. The superior head and the inferior head has different origin and different point of insertion. Although they both form a single muscle group, which is the lateral pterygoid muscle, the origin is also different and the insertion is also different from each other. So the origin of the superior head is from the infratemporal pterygoid surface and adjoining greater crest of the greater wing of the sphenoid bone, and it gets inserted into the articular disc of the condyle. Whereas the inferior head arises from the lateral part of the lateral pterygoid plate, and then it is attached to the pterygoid fovea in the anterior surface of the neck of the condyle. Nerve supply, it is from a branch from the anterior division of the mandibular nerve, and blood supply is by the pterygoid branches of the maxillary artery and ascending palatine branch of the facial arch. So again, a video which shows the origin and insertion of the lateral pterygoid muscle. The zygomatic arch will be cut for a clearer depiction of the lateral pterygoid muscle. You can see the lateral pterygoid plate here. So the deeper head of the inferior head of the lateral pterygoid muscle arises from the lateral surface of the lateral pterygoid plate, and it gets attached to the neck of the condyle. And the superior head arises from the infratemporal pterygoid surface and the greater wing of the sphenoid bone, and it gets attached to the articular disc of the condyle. So you can see the medial aspect, and the blue color shaded portion is the point of insertion of the lateral pterygoid muscle. See here, you can see this is the inferior head and this is the superior head. The superior head is clearly getting attached to the articular disc, anterior portion of the articular disc. Articular disc is a disc which is present in between the condyle of the mandible and the glenoid fossa. So what is the action of the lateral pterygoid muscle? It depresses the mandible and helps in opening the mouth along with the help of the suprahyoid muscle. It is indispensable for actively opening the mouth. It protrudes the mandible and turns the mandible or the chin from side to side. How do you examine lateral pterygoid muscle? It is palpated by examiner standing in front of the patient, and the index finger is placed in the buccal vestibule, and the patient is asked to move the mandible towards the right side if the right lateral pterygoid is palpated, and the index finger is directed medially, posteriorly, and in the superior direction. The main drawback of this method is that it doesn't reach the attachment of the lateral pterygoid muscle up to the lateral pterygoid plate. Action of the lateral pterygoid muscle. Although the superior head and inferior head together forms the lateral pterygoid muscle, the action, the origin, the insertion are all different from each other. Superior head is inserted into the articular disc of the condyle, and it is helpful in alignment of the condyle and the disc assembly. Inferior head is attached to the neck of the condyle, and it is helpful in protrusion of the mandible and in opening of the mandible. So there should be harmony between the superior lateral pterygoid muscle on one side and the retrodiscal elastic fibers on the other side, and the disc is present in between these two structures. So any sort of a disharmony between the elastic fibers and the superior lateral pterygoid is going to create a malalignment of the disc and the condyle assembly, which is going to result in a temporomandibular joint disorder.
Mouth opens. The first 20 mm opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage.
So initially it is only a minor stage which is called as anterior disc displacement with reduction, meaning the articular disc comes back to its original position upon closing. But however, in advanced stages, the articular disc is permanently fixed anterior to the condyle, and that condition is called as the disc displacement without reduction. To go much in detail regarding the action of the lateral pterygoid muscle, we will discuss about this picture in this slide. How does each muscle, each head of the lateral pterygoid muscle act? You can see during opening, the inferior head of the lateral pterygoid muscle contracts and pulls the condyle forwards. This is very obvious, but this is because this is the only muscle which opens the mandible. When the inferior head is getting contracted, the superior head is relaxed. This is because the posterior retrodiscal fibers, the elastic fibers, pulls the articular disc backwards. So when the articular disc is pulled backwards, the superior head of the lateral pterygoid must relax and allow the articular disc to go slightly posterior so that it is aligned directly on top of the condyle during maximum opening. So during closure, what happens? The reverse of the first two picture happens. The superior head of the lateral pterygoid contracts and pulls the articular disc forwards. The elastic fibers relaxes, and the inferior head of the lateral pterygoid fiber also relaxes. So never both the superior head and the inferior head contract simultaneously. When the inferior head is contracting, the superior head relaxes, and when the superior head relaxes, when the superior head contracts, the inferior head relaxes. So both the action is vice versa or opposite to that of each other. So during maximum clenching, when the patient is completely closing the mandible or closes the mouth, all the muscles of mastication contracts, but however, the inferior head of the lateral pterygoid is completely relaxed during maximum clenching. Now we will come to the occlusal disharmony and the temporomandibular joint disorder because of your deflective contact. When there is a deflective contact, as you can see in the distalmost tooth here, which is depicted in red, the centric relation is not coinciding with the maximum intercuspation. So in order to the mandible on the teeth to come into maximum intercuspation, the mandible has to slightly slide forward or anteriorly and then come into maximum intercuspation. In this case, there is contraction of the inferior head of the lateral pterygoid. In the previous slide, I told you that during maximum contraction or during centric relation, the inferior head of the lateral pterygoid muscle must be completely relaxed. If it is not relaxed, it is going to lead to some sort of a temporomandibular joint disorder. Not only temporomandibular joint disorder, patient is going to have soreness of the masticatory muscles as well. As you can see here, all the four masticatory muscles are getting contracted. So patient is going to have a problem. So in this case, the temporomandibular joint disorder is caused because of a premature deflective contact. So how do you treat it? Quite simple. You just have to keep an anterior deprogramming device. Example, a Lucia jig can be placed in the anterior incisors, and then you can relieve the posterior deflective contact, and automatically the inferior head of the lateral pterygoid muscle relaxes during maximum clenching. Because the deflective contact is eliminated, there is a coordination between the maximum intercuspation and the centric relation, and hence the inferior head of the lateral pterygoid muscle is completely relaxed. So this is a harmony between the muscles of mastication, and the patient does not have any TMJ pain, and the TMJ pain is almost immediately relieved once you give a Lucia jig. The patient will have a relief maybe in 1 or 2 days itself. Another prosthodontic significance with the lateral pterygoid muscle is the mandibular flexion. What is mandibular flexion? As you all know, the lateral pterygoid muscle is attached to the pterygoid fovea in the neck of the condyle. So when the patient is opening the mouth widely and protruding the mandible, there is an inward pull of this muscle, the lateral pterygoid muscle, which is going to pull the towards the midline. This is going to cause a mandibular flexion, and this mandibular flexion is more near the condyle and in the body of the mandible, and it is very less from the mental foramen to the mental foramen area. As you can see here, the dotted line is the original boundary of the mandible. During flexion, the condyle is moving inwards towards the midline, and this is more from the mental foramen area only, posterior to the distal to the mental foramen area. So what is the significance of this mandibular flexion? Imagine a case in which patient has a completely edentulous mandibular arch, and the patient has come to you and asked for an implant. So in this case, we have planned for a full mouth. So when we are going to place maybe around 8 to 10 implants in the mandible, and when we are going to splint all the implants together, because of the mandibular flexion near the condyle and the posterior aspect of the condyle, there is going to be a prosthetic failure. There may be an abutment fracture, there might be a screw fracture, abutment screw fracture, ceramic fracture, or in some severe cases, there might even be a implant failure. So how do we manage this case? This case can be managed with the help of placing 4 to 5 implants in the mental foramen to the mental foramen area, and the distal prosthesis is a cantilever prosthesis. Another option is placing 2 implants distal to the mental foramen area and splinting all the implants, and the fourth quadrant is a cantilever prosthesis. Another option, again in the fourth quadrant also you place 2 implants, but however you do not splint the fourth quadrant implant prosthesis with the prosthesis of the opposite side. So there is a break between the prosthesis. So in the mental foramen area, we break the prosthesis, or a non-rigid connector can be placed between the 2 segments of the prosthesis. Another option is to keep the anterior and the posterior segment separate by means of breaking the prosthesis, implant prosthesis in the mental foramen area evenly on the mental foramen area bilaterally. So by this way, anterior segment prosthesis is splinted and posterior 2 implants are splinted on the right side and posterior 2 implants splinted on the left side as well. So this way we can reduce or minimize the prosthodontic complications arising because of mandibular flexion. So with that, we are done with the major muscles of mastication. We will move on to the accessory muscles of mastication. As I told you already, accessory muscles of mastication are classified based on its position relative to the hyoid bone. The muscles which are present superior to the hyoid bone are called as the suprahyoid muscle. These are 4 in number: mylohyoid muscle, geniohyoid muscle, stylohyoid muscle, and the digastric muscle. And the infrahyoid muscle are the sternothyroid, thyrohyoid, omohyoid, and the sternohyoid. The function of the accessory muscles of mastication are to elevate the hyoid bone and depress the mandible. Mylohyoid muscle, it is a flat triangular muscle lying deep to the anterior belly of the digastric. It forms the floor of the mouth. It runs from the mylohyoid groove, which is present on the medial aspect of the mandible, and it gets inserted into the. It is flat and triangular in shape and forms the floor of the mouth. It has a major influence on the lingual surface of the mandibular tension. So what is the action of the mylohyoid muscle? It elevates the hyoid bone, it elevates the tongue and the floor of the mouth during swallowing, and also it depresses the mandible. What are the prosthodontic considerations of mylohyoid muscle? So we need to understand the origin and insertion. It arises from the mylohyoid groove on the medial aspect of the mandible and gets inserted into the hyoid. However, you see that from the mylohyoid groove, the muscle fibers are running downward obliquely towards the hyoid bone. So the muscle fibers are not running horizontally along the floor of the mouth. So there is some amount of space. The lingual surface of the mandibular denture can be extended, or maybe we can say it can be overextended, sloping downwards and medially towards the tongue. So this way, even when the muscle fibers contract and pulls the hyoid bone upwards, the lower surface, the lingual surface of the lower denture doesn't impinge on the mylohyoid muscle, and it actually creates a peripheral seal with the mylohyoid. But however, you are not supposed to extend the lingual surface of the denture under this mylohyoid groove. If you are going to extend the lingual surface of the denture under the mylohyoid groove, it is going to cause mucosal ulceration as well as muscle soreness and muscle ulceration. Also, it is going to create unseating of the denture when the patient is going to swallow the food bolus. So, this is the prosthodontic significance of a mylohyoid muscle. The other muscle is the geniohyoid muscle. It arises from the genial tubercle and it is inserted to the hyoid bone. It elevates the hyoid bone and depresses the mandible. The stylohyoid muscle arises from the styloid process and it gets inserted into the hyoid bone. It elongates the floor of the mouth. The digastric muscle has two bellies, the anterior belly and the posterior belly. Anterior belly arises from the digastric fossa lateral to the mental symphysis. It runs posteriorly downwards and then it passes through the tendon which is attached to the superior surface of the hyoid bone. The posterior belly is the longer and larger in size, arises from the mastoid process, and again it joins the anterior belly passing through the tendon of the on the superior surface of the hyoid bone. This depresses the mandible and it elevates the hyoid bone. Infrahyoid muscle are a group of 4 muscles: sternothyroid, thyrohyoid, omohyoid, and sternohyoid. So there is a peculiar harmony between the suprahyoid and the infrahyoid muscle. In the initial slides, I had told you that a muscle originates. The origin of the muscle is always from a fixed bone. Example, you take a masseter muscle, it arises from the zygomatic arch. The zygomatic arch is attached and it is immovable, it is attached to the maxillary bone. And the insertion of the masseter muscle is onto the angle of the mandible. Mandible, as you all know, it is mobile around the condyle of the mandible. But however, in this case, if you see, the hyoid bone is also a mobile bone and the mandible is also a mobile bone. So, in case when the patient wants to open the mandible, what happens is that this set of 4 infrahyoid muscle pulls the hyoid bone downwards and fixes the hyoid bone. In this case, the hyoid bone becomes the fixed bone, and taking anchorage from the hyoid bone, the suprahyoid muscle can pull the mandible downwards. So, this suprahyoid muscle helps in opening of the mandible. When the patient wants to swallow a food bolus, what happens? The patient clenches and then he swallows. By means of clenching, the patient makes the mandible a fixed bone, and taking anchorage from the mandible, the suprahyoid group of muscle pulls the hyoid bone upwards, and thereby the floor of the mouth also is lifted up. So, this way the suprahyoid muscle and the infrahyoid muscle works in harmony with each other. Buccinator, although it is not a major muscle of mastication, we cannot call it muscle of mastication, but it is important to understand the principle of a buccinator muscle as it has an influence on the polished surface of the complete denture. So, the origin, it has 3 fibers, the upper, middle and the lower fibers. All these upper fibers and the lower fibers, middle fibers run horizontally forward and gets inserted into the upper and the lower lip. The nerve supply is from the buccal branch of the facial nerve. So, the clinical significance of the buccinator muscle lies in the neutral zone. As we all know, neutral zone is a zone where the outward force of the tongue is counteracted by the inward force of the buccal mucosa. So, in buccal mucosa, you have the buccinator muscle and you have the tongue muscle, which comprises, which is present inside the tongue. So, both the forces are counteracting each other at one particular point, and that particular space is called as the neutral zone. So, when you place a denture or any prosthesis in this zone, the denture is in harmony with the surrounding oral musculature, and the denture has a better prognosis, better retention and better stability. According to Jacobson and Kroll, when he had described about the stability of a complete denture, a prosthetic space can be considered to be having 2 triangles with the apex meeting in the center of the prosthetic of the interarch space. So, as you can see, there is a triangle on top and there is a triangle below and the apex are meeting each other. So, this when the patient chews or when the patient applies force from through the buccinator muscle, the force from the buccinator muscle tries to seat the maxillary and the mandibular denture. This way, the stability of the denture is improved. Also, Jacobson and Kroll has told that the contour of the complete denture should follow the contour of this triangle. So, it should be like a triangle. You can see here the contour of the buccal surface of the polished surface should be like a triangle sloping inward towards the tongue. Same is the case in case of the mandibular denture. It should slope from outside to inside towards the tongue. If in case the mandibular denture or the maxillary denture, the polished surface of the maxillary denture is sloping outside, and if you are going to keep the teeth outside the arch form, when the buccinator is contracting or the tongue is moving, it is going to cause unseating of the denture, and the stability of the denture is compromised. How do you achieve harmony with the muscles of the oral musculature? This can be done by the neutral zone impression techniques. After the maxillary and mandibular cast is obtained, you fabricate the maxillary record base and the mandibular record base, and retentive wires are being incorporated into the maxillary and the mandibular record base. A soft impression material like a green stick compound can be placed on top of the mandibular arch, and this mandibular record base is inserted into the patient's mouth, and the patient is asked to do the tongue movements and other functional movements like sucking of the lips, chewing, smiling. All these things are done, or functional movements are done, and the neutral zone is recorded. So once the neutral zone is recorded, this can be duplicated and it can be converted into occlusal rim, and the teeth can be placed inside the neutral zone. On the contrary, when the teeth setting is being done and the patient is called for the wax trial, in the wax trial phase also, you remove the wax from the buccal and the labial surface of the denture, inject the polyvinyl siloxane impression material, insert the trial denture into the patient, ask the patient to do some functional movements, and the oral musculature is recorded on the labial and the buccal surface of the polished denture. On the polished surface of the denture. This way, not only the intagli surface is recorded with the help of impression material, but the polished surface also is recorded with the help of a movement of the tongue as well as movement of the buccal mucosa. So to conclude, I would like to say that where you live, abide with it. This holds good for individual as well as for denture. So you can say that when you are going to fabricate a prosthesis, the prosthesis has to be in harmony with the surrounding musculature. You are going to do a complete denture, it has to be in harmony with the muscles of mastication, the major muscles of mastication as well as the accessory muscles of mastication. If you are not going to create a prosthesis which is not in harmony with the oral musculature, then it is going to cause unseating of the denture, and the patient is going to have a poor stability of the prosthesis. So unless a dentist has a thorough knowledge of anatomy and physiology of the supporting structures, fabrication of prosthesis which functions in harmony with the supporting musculature is not possible. So with this, I conclude this session. I hope I have made my point clear to most of all the candidates who have been present for this webinar, and I would be pleased to answer any doubts, and please let me know if you have any doubts, and I would answer to the best of my knowledge. Thank you once again. Have a good day.